Good morning, everybody, and thank you very much to the organizers, Manjit and team, for giving me this opportunity to be here today. The topic that has been given to me is about revolutionary approach to transfusion practice. I'm not going to talk about anything revolutionary, but what I'm going to do in the next few minutes is talk about some controversies that always has accompanied transfusion practice. As you all know, as Sarah has mentioned, uncontrolled bleeding is a leading cause of death in the postoperative following a trauma. This can occur, either the patient can die immediately after an accident, or he can develop a coagulopathy which occurs in the first 30 to 1 minutes to 1 hour and exsanguinate. Because coagulopathy is an integral part of trauma and it can happen at the site of injury or subsequently. Now, the term massive transfusion protocol, please don't misunderstand it for the regular MTP. Massive transfusion protocol means that you have given 10 units of blood or blood products in the first 24 hours. Now, it accounts for only a small proportion of what you normally see or the normal transfusion practice that occurs in the hospital. But if you do not take care of it properly, it can cause significant morbidity and mortality. You come across massive transfusion protocols inside the hospital when you have obstetric cases, postpartum hemorrhage, cardiac surgery, as well as in liver transplant. You see a lot of bleeding where massive transfusion protocols have to be followed. Now, the concept of massive transfusion protocol actually came from damage control resuscitation. Sarah has already told you about it. Rapid control of bleeding or source control, minimization of colloids that is to be used, permissive hypotension, and early use of blood and blood products. Now, massive transfusion protocols involves the use of plasma platelets and red cells, and adjuvant like tranexamic acid or fibrinogen may be added. What I'm going to do today is talk about 2 or 3 specific areas of contradiction which will be discussed here. The first is, since we have discarded using whole blood, we have been using fixed ratios, component therapy, which means that plasma platelets and red cells are being used in a ratio of 1:1:1, which is recommended by all the bodies. Now, is this the appropriate ratios that is to be used? Whether it can be 1:1:2 or something different is the first question. The second question is that over the years, especially in the last 2 decades, viscoelastic hemostatic assays has come up in a big way. Now, if you have on one side you have fixed ratios, the other side you have advanced tests like VHA. How do these two merge with each other? That's the second question that we have to answer. And third thing is that the wheel has come full circle from the time when we discarded whole blood in the 80s. We have come back to the point where we want to use whole blood once again. I will not be discussing the last point because of the shortage of time. So let us go to the ratio-based transfusion practice. Now, traditionally, that is early years, the 60s and the 50s, we used to manage most of our trauma patients using crystalloids and red cells, and they found the mortality was unacceptably high. Subsequently, when the component therapy came up, we started using 1:1:1, that is plasma, platelets, and red cells in a ratio, in the same ratio, and they found that this was associated with a significant reduction in mortality in the military experience, which was subsequently transferred over to the civilian practice. Remember that most of the practice that we have regarding trauma is actually acquired from military practice. Now, the ratios were fixed as 1:1:1. But there was a lot of controversy. Some people tried to use 1:1:2 and etc. And therefore, this trial, which is known as the proper trial, PROPRR trial, was conducted published in 2015. They actually started in 2010. It involves about 680 patients. What they looked at was whether 1:1:1 was superior or inferior to 1:1:2. That means more red cells and less plasma and platelets. And what they looked at was 24-hour mortality as well as 30-day mortality. And they found that significantly better hemostasis was achieved with 1:1:1 ratio, although these patients received no blood products. There was no difference in the ARDS, AKI or sepsis. However, as far as mortality is concerned, there was no difference in 24 hours or 30 days. Now, a few years later, Lammers et al. Actually came up using advanced statistical analysis as well as Bayesian analysis, showed that although the proper trial did not show any mortality benefit, there was actually much significant mortality benefit at multiple time points during the first 24 hours. This was not reflected up at the 30-day mortality. And this was again, so it was accepted once and for all that we have to use 1:1:1 as a fixed ratio to be used in the society. Now, simultaneously other advances have been made. One of the things that is actually coming up in a big way is called the high mobility group box 1. It's a damage associated molecular pattern. Now, this molecule is actually released immediately on injury. And what is more important is that this HMGB1, the proportion that is present in the blood is directly proportional to the severity of the injury, the number of transfusions that is required, and the outcome of the patients. And they also identified that a value of more than 30 micrograms per liter means that you have to call for massive transfusion protocol. The unfortunate part is that this molecule is not, there is no point of care test which can easily which is easily available for an ED person to identify, okay, this is the level of this particular patient and therefore I have to call an MTP. So that is one of the things. Second, further advancements have been made in the field of phenotyping, which I am not going to discuss here. So now most of the centers follow the same as 1:1:1, which means they use 6666. The reason being that many of the advanced AD centers use single donor platelets. Single donor platelets, as you all know, is equivalent to about 5 to 6 units of platelets. So mix it with, combine it with plasma as well, platelets as well, plasma as well as red cells. The other important thing to remember is that what is the plasma that you're going to give? Especially for the postgraduates in the group, remember that it is AB group plasma. It can be AB positive or AB negative. The antibodies in these are not very strong. So AB plasma is one that is to be stored in the EDs. The most important thing, which I want to stress again, is that if you want to have an efficient emergency department and massive transfusion protocol, these products should be available 24 hours in the ED. It cannot be ordered one by one from the blood bank, and that will not correct your coagulopathy because it has to be given rapidly and almost simultaneously to all the patients. Now, in the operating room, we come across similar situations, especially when postpartum hemorrhage is present. And here, the obstetric postpartum hemorrhage protocol also ensures that your fibrinogen level has to be more than 200 milligrams per cent. During varicose bleeding or peptic ulcer, the primary responsibility of the anesthesiologist is to manage the coagulopathy and the circulating blood volume. In cardiac surgery, we use VHA-based assessment of these management, although when we actually come off bypass, we use the fixed ratios to give to the patients. Now, coming to the viscoelastic test. Now, when you look at conventional coagulation test, that is your prothrombin time or thrombin time, all these, remember that all these tests actually stop, or the end of the test is when the clot starts forming. Whereas when you use the viscoelastic test, the TEG or the ROTEMs, it actually goes through the entire process of clot formation, helps you identify what is the role each of them is playing, whether there's any deficiency. More importantly, viscoelastic test also gives you a lot of lateral thought, because there may be patients who are having deficiency of cryoprecipitate or fibrinogen deficiency, or hyperfibrinolysis may be existing in these patients. So the question arises is that whether you should go on with fixed ratio component therapy, or whether we should go on to management of patients with viscoelastic tests being freely available. Now, there was one study by Gonzalez and colleagues where 111 patients were used. They fixed ratios with CCA was used as conventional coagulation analysis, or VHA-based assessment was carried out, and they found that there was a significant reduction in mortality when VHA-based assessment was carried out. Another study called the ITATIC study is a large study which looked at two things. One is alive and free of massive transfusion protocol at 24 hours and 20-day mortality. They found no difference at 24 hours as far as massive transfusion protocol is concerned, and there was no difference in the mortality at 30 days. However, in a subgroup of patients with traumatic brain injury, they found that if you use VHA-based as management of these patients, there was a significant reduction in the mortality. Now, a few years later, there was a reassessment of the ITATIC study, and they found a number of mistakes that were carried out by the people who conducted the study. For example, they found that 71% of the patients who were actually coagulopathic when they arrived in the ED, 16% developed coagulopathy during therapy. Only 54% of the patients who were slotted to the VHA group actually had goal-directed treatment. And finally, only 20% of the patients in the VHA group actually had their coagulopathy treated. And the authors concluded that ITATIC study was not a proper study, primarily because most of the products arrived late, the coagulopathy was not treated properly, and therefore this could not be taken as an indication. A meta-analysis was subsequently conducted with 10 studies which showed that VHA was good, but there was no robust evidence to suggest that VHA should be the path forward. And then we have the European Society of Anesthesiology, which supports the use of VHA during massive transfusion protocol, but the level of evidence was a little low. Now, no study has actually shown harm with VHA. And what is important to remember is that the VHA versus fixed component therapy are not exclusive of each other. When a patient comes with massive trauma to your ED, the important thing to remember is that start your fixed ratioed component therapy. Simultaneously send a sample of blood for VHA. VHA will help you to think laterally. It's an adjuvant to fine-tune your management of these patients, because it tells you whether the patient has got hyperfibrinolysis, in which case you have to give tranexamic acid, whether there is a component therapy deficiency. For example, it is the cryoprecipitate is not adequate because your 1:1:1 doesn't contain anything about fibrinogen. So these are the things that helps when you do a VHA. So today the present concept, or the concept, is that VHA and fixed ratios go hand in hand. They are adjuvant therapies, and it should be used in every patient. The last part of my talk is about whole blood component therapy. Interest in whole blood has come back again based on the military experience, which has shown that when you use whole blood, there is a massive reduction in 24-hour as well as 30-day mortality. Now, what is the blood that is to be used? Again, O positive blood, RSD positive blood is the one that is to be used. Now, this is low titer O positive whole blood is what is to be used when you talk about whole blood therapy. This whole blood can be stored at 4 degrees for 21 days, and it gives you the beneficial effects. There are a number of studies which I am going to ignore because of the shortage of time. But a few important things, important things to remember. When you talk about whole blood, remember that it's a double, it's a major advantage in the sense that you have 450 ml of blood, which is a volume therapy. And you are giving a blood which has got 42% hematocrit, 250,000 platelets, and 100% coagulation factors available in the blood. So it is complete therapy in the sense that you are giving volume replacement as well as component therapy. So a lot of, from the question whether should we use whole blood, we should now change over to how to use whole blood safely and effectively. No patient is safe. Not safe. However, whole blood is not safe in certain subgroup of patients, those with rare growths where there may be a lot of antibodies or strong allo antibodies are required in these patients. Remember one thing, even in pediatric patients having trauma, we have started using whole blood, but taking into consideration the volume as well as the titers that is used. A few words like, sorry, what else? Now, just want to stress what Sarah has already said about tranexamic acid. Remember, all the PGs should know what is a crash trial. Crash trial is a major trial of 20,000 odd patients. 40 countries were involved, and it clearly showed that you have to use tranexamic acid, and tranexamic acid should be used within 3 hours of an injury. It also applies to your surgery. When you do surgery, remember before the skin incision, your tranexamic acid has to go. Then only the benefit will be seen. And if you have a massive transfusion protocol, give your tranexamic acid immediately. The last thing, as I said, is about the lethal triad of hypotension, hypothermia, and coagulopathy is now replaced with the lethal diamond, which is in addition to which you also use hypocalcemia. So in summary, MTP is critical. Component therapy 1:1 has to be used, but always use it in conjunction with the VHA-based analysis. Whole blood has come back in a big way, and the low titer O positive whole blood is the one that is to be used in these patients. Thank you very much.
Thank you, sir, for simplifying such an essential and impactful topic. Traumatic brain injury remains one of the most critical challenges in emergency care. From ICP management to neuroprotective strategies, each decision can influence neurological recovery.